Welcome to Medical Grand Rounds. It's my great pleasure to have back someone who's been a longtime mentor to many of us in the department. And I think known to all of you, unless you joined within the last couple years. So requires not much introduction. He's internationally known for his work on hyponatremia. And I'm really pleased that he's able to speak to us today. And Dr. Rsterns will be telling us about the, only he can put this in a title, Pisse Prophecy and the Bump. Dr. Rsterns.
Good morning. It's great to be with you. So our topic is Pisse Prophecy and the Bump. What is Pisse Prophecy? Well, in the Middle Ages, examination of the urine, guided by the urine wheel, was the physician's most important diagnostic tool. It surpassed palpation of the pulse. And I've always affectionately referred to these ancestral nephrologists as Pisse Prophets. But that actually, I have to tell you, it's not historically accurate. Pisse Prophet was a pejorative term. It was introduced in a pamphlet written by Brian Thomas in 1637, in which he decried the debasement of this ancient art by quacks and charlatans who used urine to tell fortunes instead of for diagnostic purposes. But I'll stick with the term, and I think Shakespeare would approve. Falstaff says to his page, "What says the doctor to my water?" And the page says, "He said, sir, the water itself is a good, healthy water, but for the party that owned it, he might have more diseases than he knew for." So much for Pisse Prophets. What's the bump? That stands for Basic Urine Metabolic Profile. And we'll be talking about its use in the diagnosis of fluid and electrolyte disorders. And now you know why I chose the title Pisse Prophecy and the Bump, because if I used the other, none of you would be here right now. But to talk about the bump, or the basic urine metabolic profile, we often also have to go back into ancient history, back to when I was in grammar school, when the autoanalyzer was first developed. And by the time I was an intern and resident, the SMA 12 and the SMAC were in widespread use. And from the very beginning, the autoanalyzer was used to measure chemistries in urine. Now, we're familiar with the use of the autoanalyzer to measure blood chemistries. We call it the basic metabolic panel. It includes, in our lab, sodium, potassium, chloride, CO2, butane, creatinine, calcium. They all come together. We seldom order them individually. But urine chemistries, for some reason, despite the fact that they're measured together by the autoanalyzer, we order them separately. There is now, and thanks to Dr. Roberto Vargas in the lab, an order set that allows you to order all of these together. It says chemistry urine panel random with calculated osmolality. Now, I'm still working a little bit on that calculated osmolality, but let me tell you about it. You're familiar, I think most of you, with the calculated plasma osmolality. To calculate the plasma osmolality, you take twice the serum sodium or plasma sodium concentration, and you double it because each sodium comes with an anion. And then you do some arithmetic to convert the osmotic contribution of urea and glucose from the units milligrams per deciliter to millimoles per liter. Now that calculation omits potassium, and so that would underestimate the plasma osmolality a bit. And it also assumes that the sodium salts dissociate completely, so that you get a sodium and a chloride particle, each measured by the osmometer, but in fact they don't completely dissociate. So that gives you a little bit of an overestimate, and that those offset. Well, what about the calculated urine osmolality? For that, you take twice the sum of urine sodium and potassium. You include potassium because sometimes urine potassium is actually higher than urine sodium. Again, you double it because of the anions. And again, do this mathematics to convert milligrams per deciliter of urea and glucose into millimoles per liter. Now that calculation omits urine ammonium, which underestimates a bit. And it makes that same assumption that these salts completely dissociated. They don't. So that's a little bit of an overestimate. And those errors offset. And the calculated urine osmolality using that formula is remarkably accurate. This is from 3 population studies with over 4,000 patients, and the estimated urine osmolality was within 5% of the measured urine osmolality. And that works, it's a close estimate for both normal subjects and for subjects with kidney disease. Now, why bother? Well, this interested the lab because if you measure the osmolality directly, you use a desktop machine called an osmometer. Only one sample can be measured at a time, and it's labor intensive. It takes about 5 minutes of technician time to complete a single measurement. But this is our auto analyzer, and it is 10 times faster than the osmometer. It doesn't require any extra technician time. So how can you use the calculated or the measured urine osmolality? Well, we can use it to evaluate polyuria, for example. Now this polyuria is defined by a urine output of more than 3 liters a day. And you can divide that urine volume into osmolar clearance and free water clearance. Osmolar clearance is the ratio of urine to plasma osmolality multiplied by the urine output, and free water clearance is the urine output minus osmolar clearance. So you can divide polyuria into two types. It can be a solute diuresis in which osmolar clearance exceeds 3 liters a day. The urine osmolality is typically about 300, and it could be from salt, glucose, urea, or mannitol. And then a water diuresis, the free water clearance is more than 3 liters a day. The urine is dilute, and that could be due to primary polydipsia, central DI, or nephrogenic DI. So if you have somebody with a solute diuresis, that could be from salt and water, in which most of the urine osmolality is accounted for by sodium and potassium salts. Or it could be to an osmotic diuresis from glucose, urea, or mannitol. And when you measure the urine osmolality with the bump, you've got the data because you know exactly how much glucose and urea are in the urine. The diagnosis becomes simple if you have all the data. So let's talk about how the individual components of a basic urine metabolic profile can help you. And let's begin with creatinine. Now, to remind you, creatinine is about muscle. Creatine is synthesized in the liver and is taken up by skeletal and cardiac muscle. Some of it becomes creatine phosphate, which is an energy source. And then at a constant rate, there is non-enzymatic, irreversible conversion of creatine or creatine phosphate to creatinine. And that's released from muscle at a constant rate. And it's handled by the kidney, mostly by glomerular filtration and a small amount by tubular secretion. And so that means that creatinine is excreted at a constant rate in the urine, and the amount is determined by muscle mass. So how can we use this to our advantage? The amount of a substance excreted is equal to its urine concentration times the urine volume. So let's take somebody who has a urine protein concentration of 100 milligrams per deciliter. That's what you get when you take a urine sample and measure the urine protein in it, or take a dipstick and put it in there. Was that a lot? Well, if the urine is very concentrated and the urine volume is very small, that's not too bad. But if the urine output is 4 liters a day, the patient is nephrotic. So when you measure the concentration of something in the urine, you want to have some idea of what the urine volume is. And this is how the urine creatinine can let you do that. All of the filtered and secreted creatinine is excreted in the urine. It's not reabsorbed by the kidney. So creatinine production from muscles is equal to creatinine excretion. And daily creatinine excretion is about 1 gram per 24 hours. So that means that if you take the urine volume and multiply it by the urine creatinine concentration, that will give you about 1 gram of creatinine in 24 hours. The urine volume in 24 hours times the urine creatinine concentration is about 1 gram. So urine volume, if we just turn the equation around, urine volume equals 1 gram of creatinine divided by the urine creatinine concentration. Now, creatinine concentration is reported in milligrams per deciliter. That's a milligram for 1/10 of a liter. And to correct for that, the urine volume in liters per day equals 100 divided by the urine creatinine concentration in milligrams per deciliter. So we actually use this, use it quite commonly in the urine protein to creatinine ratio. Occasionally we use it for the urine uric acid to creatinine ratio, or the potassium to creatinine ratio. Now we should notice or note that assuming the creatinine excretion is 1 gram is an underestimate of urine volume in a young muscular man who excretes quite a bit more than 1 gram per 24 hours. And it's an overestimate in old frail subjects who excrete less. So let's review. Urine creatinine concentration of 100 milligrams per deciliter means that there's about 1 liter of urine a day. 50 milligrams per deciliter means there's about 2 liters of urine a day. And 25 milligrams per deciliter means 4 liters a day. Now, you could double the estimate for a young, muscular, tall man and have the estimate for an elderly, frail, short woman. Or you could get even a little bit more fancy. The estimated glomerular filtration rate, which is in the lab report, is based on things that determine muscle mass: age, sex, and it includes race. That's now controversial, and I think in the near future that's going to be taken out of the estimated GFR. But it provides you an estimate of the glomerular filtration rate per 1.73 meters squared of body surface area, and it's calculated from the serum creatinine and these above 3 variables. And you can use that to advantage to kind of adjust for age and sex in the estimate. And the assumptions are that the eGFR is about equal to creatinine clearance. That's actually a rough estimate. It's not totally true. But that, again, remember that the creatinine clearance equals the creatinine excretion rate divided by plasma creatinine concentration. And to get the creatinine excretion rate, you multiply the urine creatinine concentration by urine volume. So do a little algebra, and the urine volume equals the eGFR times the ratio of plasma to urine creatinine concentrations. And in this paper, in a small number of patients, that estimate did a pretty good job of estimating urine volume. You can see here measured urine volume and calculated urine volume are rather close to equaling each other. That's the line of unity on the diagonal. Now, how else can we use this? We can put creatinine concentration and the sodium concentration together to our advantage. Now, this is a calculator which you can find online. It was put there by a cardiologist, Dr. Testani, a Yale cardiologist. And this is called a diuretic response calculator, which can estimate the sodium excretion after you give a diuretic from a spot urine sample. Now, once the cardiologists get involved, you must accept that there's something to this. Here, he assumes that the GFR, again, is creatinine clearance, but notices that this is really per body surface area, okay? So this, being much more precise, makes corrections for body surface area and asks you to enter the patient's, not just the age and weight, but the patient's height into the equation, and it'll make that correction, and it'll give you from the urine sodium concentration and the urine creatinine concentration in a urine sample obtained 2.5 hours after giving a diuretic, an estimated sodium excretion. This was this estimated sodium excretion versus here predicted versus what was actually measured. And they correlate extraordinarily well. And this is from a spot urine sample to accurately predict how much sodium is going to be excreted after administering a diuretic. Now, that was put to use. And here in this recently published paper in Journal of the American College of Cardiology, he gave a patient a loop diuretic, used this calculator and a spot urine specimen to predict the natriuretic response, and then based on that, adjusted the dose. It's a nurse-driven protocol with frequent, up to 3 times a day, up titration of the diuretic dose, rapidly escalating it to achieve an effective diuretic dose in patients with severe congestive heart failure. Now, this proved to be better than measuring weights or having the nurses measure urine volumes. And there is going to be a triple-blinded randomized trial comparing spot urine-guided diuretic treatment to usual care. Let's talk about potassium and creatinine and how you can use the creatinine and potassium concentration in the bump. Here's a previous healthy 22-year-old man, and he wakens in the morning and he's paralyzed. I hate it when that happens. He's hypertensive, his thyroid is diffusely enlarged, he's tachycardic, he has a flaccid paralysis of all of his extremities, his EKG shows sinus tachycardia and flat T waves. These are his blood chemistries. His serum potassium is 2. And his urine creatinine concentration, his serum, let me try that again. His serum potassium is 2. His urine potassium is 12 milliequivalents per liter. His urine creatinine concentration in milligrams per deciliter is 120. So let's do our math. Again, we want to take, we have the urine potassium in milliequivalents per liter, the urine creatinine in milligrams per deciliter. So we have to multiply by 100 to get the ratio that we want, which is the urine potassium excretion per gram of urine creatinine, which is an estimate of urine potassium excretion per day. 12 milliequivalents per liter in the urine. Creatinine is 120 milligrams per deciliter. That means about 10 milliequivalents per gram of urine creatinine, and an estimate of 10 milliequivalents of potassium excretion per day. That's about 1/7 of what usually comes out. Now, this patient was treated with 80 milliequivalents of potassium over the course of 8 hours, and his muscle weakness resolved. Notice that his serum potassium increased from 2 to 5.8 after that small dose of potassium. This is thyrotoxic periodic paralysis. And after giving potassium therapy, characteristically, there is rebound hyperkalemia that you'd like to avoid. So you'd like to make this diagnosis before you start treating with potassium. This is a series of patients who are paralyzed with hypokalemia. Some of them, those in the dark circles, have a form of periodic paralysis. And the other circles have severe hypokalemia from some other cause. It's not periodic paralysis, hyperaldosteronism or distal RTA, etc. Now, this is the urine potassium concentration of those subjects. And you see there's a lot of overlap. But if you take the urine potassium to creatinine ratio, there was a very nice separation, a reliable cutoff of about 13 milliequivalents per gram of creatinine in a spot urine sample. So some of you may have tried to understand the TTKG in evaluating potassium disorders. Well, you can forget about it. It's hard to explain. It has no advantage over this rather simple urine potassium creatinine ratio. Its physiological assumptions are invalid, and it's been abandoned by its creator. Let's go to another electrolyte that we can find in the basic urine metabolic panel, the chloride. Here's a young woman with hypokalemia. She's a 17-year-old high school senior, and she fainted at home. She's been lightheaded with a lack of energy for several months. She denies vomiting, taking no medications or illicit drugs. The family eats dinner together, and the parents confirm that she's eating a normal meal. But she has a gastric colic reflex, and she has to have a bowel movement within an hour of eating a big meal. Now, her physical examination shows that she has postural hypotension. And her serum electrolytes show that her potassium is 3.1. Now, in the differential diagnosis of hypokalemia, our first step is to look at the urine potassium creatinine ratio. If it's less than 13 milliequivalents per gram of creatinine, it's either due to a cell shift, as in periodic paralysis, as we've just seen, or to gastrointestinal loss. And if it's greater than that, that's renal potassium wasting. Well, let's look at her urine chemistries. Her urine sodium is 52, his urine potassium is 50, and her urine creatinine is 100 milligrams per deciliter, roughly a liter of urine a day. So her urine potassium to creatinine ratio is much higher than 13 milliequivalents per gram. We make a diagnosis of renal potassium wasting. When we have a diagnosis of renal potassium wasting, we then look at it further by looking at the blood pressure, the patient's volume and acid-base status. Well, she's hypovolemic, her blood pressure is low, and her venous blood gases confirm with her electrolytes that she has a metabolic alkalosis. So this is normotensive, hypotensive renal potassium wasting with a metabolic alkalosis. We can forget about renal tubular acidosis. So she has a low blood pressure, a high serum bicarbonate, and what about her urine chloride? Her urine chloride is less than 1 millimole per liter, with a urine sodium, which is much higher. We make a diagnosis of surreptitious vomiting confidently. She was told that her blood and urine tests indicated chronic vomiting. No other diagnosis was possible. She was eventually admitted. No, she eventually admitted, excuse me, she fessed up that she wasn't eating the lunch that her mother made her for school. And when she had dinner, that gastrocolic reflex was really an excuse to go to the bathroom to purge. She got some psychiatric help, and they were together. They were able to stop her bulimic practice, and the story has a nice ending. She became a professor of nursing. So let's see how we can use the urine chloride and with more specifically the urine sodium to chloride ratio to evaluate patients with hypokalemia. It's a recent series of patients with surreptitious disorders, either bulimia, laxative abuse, or diuretic use, or patients with renal tubular disorders, often inherited like Gittleman's or Barter's or distal RTA, which can be either acquired or inherited, and these can cause severe hypokalemia. And on the left panel, it shows the urine sodium in dark bars and the urine chloride in white bars, and these various causes of hypokalemia. And on the right, the urine sodium to chloride ratio. And there's anorexia bulimia. It stands out like a sore thumb with a high urine sodium to chloride ratio. And there's laxative abuse, which also can be separated. Let's see why that works. Now, if you have Barter's syndrome, that's like you're taking a loop diuretic. And if you have Gittleman syndrome, that's like you're taking a thiazide diuretic. These are chloride wasting disorders. So the urine chloride matches dietary intake. If you have hyperaldosteronism, your volume expanded, and so that decreases the proximal reabsorption of sodium chloride. It too is a sort of a chloride wasting disorder. The urine chloride eventually matches dietary intake. But this is gastric alkalosis. What happens if you're losing hydrochloric acid from your stomach? That generates a metabolic alkalosis. It provides sodium bicarbonate to the bloodstream. So when you have an excess of serum bicarbonate, that increases the urine excretion of sodium bicarbonate and potassium bicarbonate. But the loss of chloride from the stomach makes you chloride depleted, which decreases the urine excretion of chloride. And so you have plenty of sodium in the urine, very little chloride in the urine, which increases the ratio. Eating disorders are a very common cause of hypokalemia. And the urine chemistries can help you sort this out. You want to look for changing serum and urine chemistries. With surreptitious vomiting, the urine chloride is typically low, as we've seen, due to the loss of hydrochloric acid, and there's renal potassium wasting. With diuretic abuse, it can really look like Gittleman's or Barter's syndrome. But instead of the urine chloride always being at a constant level as it is matching intake, as it is with Gittleman's and Barter's, the urine chloride fluctuates wildly. So serial urine chemistries can help you make that diagnosis. And cathartic abuse is another cause of hypokalemia that can be confusing. And the urine chemistries can help. Cathartic abuse can mimic renal tubular acidosis. Both disorders cause hypokalemia. Both disorders can cause a hyperchloremic metabolic acidosis, a normal anion gap metabolic acidosis. And in both disorders, the urine pH is not low. Now, why is the urine pH not low? It's because of ammonium in patients with diarrhea or cathartic abuse. Ammonium is the kidney's vehicle for the excretion of acid. It's made by the kidney, and urine ammonium excretion is low in patients with renal tubular acidosis. That's why they got the acidosis, because they have a tubular defect in ammonia production. But in extrarenal acidosis, acidosis is caused from something outside the kidney. The kidneys respond to the acidosis by making more ammonium. Now, unfortunately, urine ammonium is not routinely measured by clinical labs, but we can use a surrogate. The calculated urine osmolality, which we've already talked about, and compare it to the measured urine osmolality, the urine osmolality measured with an osmometer. Again, remember, this was our formula for the calculated urine osmolality. And we said that we knew about an error, that it emitted ammonium. It's usually not that high, and so it will just offset in errors. But if the urine ammonium is quite high, there will be a gap, a large gap between the measured and urine osmolality. High concentrations of urine ammonium increase the measured urine osmolality. They don't increase the calculated urine osmolality. And if you take the urine osmolar gap and divide it by 2, that gives you approximation of urine ammonium excretion. And a urine osmolar gap that's over 400 tells you that there's a non-renal cause of acidosis. So in cathartic abuse, the loss of alkali in the stool will cause a metabolic acidosis and a high urine osmolality caused by the increased production of ammonium. Now, this is also true of another disorder that can mimic RTA, which we see occasionally, glue sniffing. It's important to find it because it can be very bad for you. And it was thought for a while that glue sniffing actually caused RTA, but what it really does is toluene is metabolized. Toluene is what's in glue that you inhale as an intoxicant. It's metabolized to hippuric acid. And that influx of acid will cause a non-ion gap acidosis. But again, there is a high urine osmolar gap because it's an extrarenal form of acidosis. And as we've said, in renal tubular acidosis, there is a low urine osmolar gap. And so it becomes, because of defective excretion of urine ammonium, which is the cause of acidosis. Some of you may have spent time trying to understand the urine anion gap. Well, you can forget about it. The urine anion gap is based on faulty assumptions. It fails in patients who are glue sniffing. It'll not pick it up, and it has no advantage over the urine osmolar gap. And in this recent paper, its assumptions were thoroughly debunked. Let's take another element in this basic urine metabolic profile, the urine urea nitrogen. And let's take another patient. This is a 34-year-old woman, and she presents with hyponatremia. And she's been hyponatremic pretty steadily over the past 3 months. She's a strict she's a strict vegetarian. On a low salt diet, she drinks a ton of water, takes a lot of vitamins, denies using laxatives or diuretics. Now she's admitted to the hospital. And this table shows what happens when she's taking her usual diet. And then after 2 days on an 80-gram protein diet, which she's asked to eat, and then 3 days after discharge when she returns to her ad-lib diet. Notice that her water intake is about 5 liters a day, and her urine volume matches that. On her ad-lib diet, she's hyponatremic, even though she can maximally dilute her urine to 81. And her urine electrolytes, which look low, aren't really, those are concentrations. And if you multiply it by her water intake, they're not that low. But her urine urea is remarkably low. It says there, this is her urine urea on her usual diet, and then after going to her 80-gram protein diet. On her ad-lib diet, her estimated dietary protein intake is about 26 grams a day, about 1/4 what I eat. So 10 grams of dietary protein will yield 50 millimoles of urea. So a normal diet, or what we call normal, will give us 300 to 400 millimoles of urea in our urine, about 500 to 600 millimoles of electrolytes, and a total solute excretion of 900 milliosmoles per day. And this patient's diet only had 130 millimoles of urea, and her total solute excretion was less than 300 milliosmoles per day. This slide compares free water clearance here on the ordinate to urine osmolality as you fall down to maximally dilute urine. And these 3 lines reflect different dietary intakes and urine solute excretions. You can see with a typical Western diet, I'm taking in 900 moles of solute and putting it out in the urine. Your urine output can go to about 1 liter an hour. But on this patient's solute intake of only 300 milliosmoles per day, you can see that her urine output struggles to match her intake. Urine output equals daily solute excretion divided by urine osmolality. And a low solute intake is the cause of hyponatremia in patients with beer, potomania, and patients on a tea and toast diet. The urine solute contains both electrolytes and urea, and the urea fraction of urine solute is important. In fact, we can use urea to treat hyponatremia. Increased urea excretion increases urine volume, just as decreased urea excretion decreases it. And increased urea excretion decreases urine electrolyte concentration and increases urine electrolyte-free water losses. The bump is actually helpful in hyponatremia. It's helpful in the diagnosis. You get a urine osmolality, you can calculate. You get a urine sodium, you get the urine volume, you can estimate urine urea excretion, and it's helpful in therapy with the urine to plasma electrolyte ratio and the electrolyte-free water clearance. This is the urine to plasma electrolyte ratio. From a spot urine sample, it can be very helpful. It's the concentration of the sum of urine sodium and potassium concentrations divided by the plasma sodium concentration. And if that ratio is greater than 1, it means the urine is very hypertonic. Water restriction will be predictably ineffective. If it's between 0.5 and 1, you can use water restriction, but you got to really restrict it. And if the ratio is less than 0.5, you know that the urine is half electrolyte-free water, and so you can correct hyponatremia effectively. Now, that ratio becomes even more important if you consider urine volume. Again, urine output we'll call V, and you can divide urine output into electrolyte clearance, which is the product of urine output and that urine to plasma electrolyte ratio. And then electrolyte-free water clearance is the urine output minus electrolyte clearance. So you can estimate electrolyte-free water clearance from a spot urine sample and the serum creatinine concentration. You can estimate urine output, as we've said, from the urine creatinine concentration, or if you want to get fancy, you can factor in the eGFR. You have the urine to plasma electrolyte ratio. For that, you need the urine sodium and potassium concentration and the serum sodium concentration. You can use electrolyte-free water clearance to help you prevent rapid correction of hyponatremia. If you obtain serial spot urines to monitor electrolyte-free water clearance, which can change during the course of therapy, it tells you how much D5W you would have to give to prevent the serum sodium concentration from increasing. And the electrolyte-free water clearance can also help you recognize and prevent hyponatremia due to desalination of intravenous fluids. If you have a very hypertonic urine with a high urine to plasma electrolyte ratio and combine that with a large volume of isotonic fluid, we see that all the time in patients with subarachnoid hemorrhage, and we sometimes see that in postoperative patients. And even though you're giving the patient isotonic fluid, because they're excreting very hypertonic urine, they can desalinate the isotonic fluid and become hyponatremic. The estimated electrolyte-free water clearance here is negative, meaning that you are retaining, or the patient is retaining, free water, and you've got a problem. There are other uses of the bump, which you probably use a lot of the time. The fractional excretion of sodium, you've got it. The fractional excretion of urea, you've got it. And these are helpful in the evaluation of oliguria and acute kidney injury. So what are the benefits of the bump? This can provide diagnostic triumphs. You can amaze your friends, making the diagnosis of periodic paralysis from the potassium creatinine ratio and avoiding iatrogenic hyperkalemia from giving too much potassium. You can recognize surreptitious vomiting from the urine sodium to chloride ratio. You can make the diagnosis of cathartic abuse and glue sniffing due to the using the urine osmolar gap. And you can monitor therapy. You can monitor the diuretic response from the estimated urine sodium excretion. And it can help you manage hyponatremia using the urine plasma electrolyte ratio and the estimated urine volume. If you don't remember any of this, remember this. If you see an abnormal basic metabolic profile and you're not sure what's causing it, order a bump. Order a bump and help the Pisse Prophets do their thing. Thanks, and I can take your questions if any of you are still left.
You have 100 people still left. So there is, let's see. Mary Cohen asks, how do the labs adjust EGFR for weight and height? And I think the answer is they don't, right? It's reported per 1.7 meters squared.
That's right. That's precisely right. And that's why this fancy calculator that the cardiologists have introduced puts you need a height and weight to enter it, and then you transform GFR per 1.73 meters squared to GFR, right? By converting per body surface area, you enter what the body surface area is, and then you can calculate it.
So let's see. Mahesh Nepal asks, if a patient with pulmonary edema with hyponatremia is being diuresed with Lasix, overcorrects sodium, will the bump help?
Yeah, well, you can see, again, when you give Lasix, you actually excrete a hypotonic urine, and it's going to vary over time. This is a good example of something which will change. And while measuring something serially will help you see what's going on. While you're taking the diuretic, if you're responding to it, you can see that the urine is hypotonic. You can actually calculate the electrolyte-free water clearance, which will tell you a good estimate of how much water is being lost and how much water you would have to replace to prevent that overcorrection from occurring. Or to see that it's working. If you want to make the serum sodium go up, you see, yep, it is. It will.
Yeah. So this seems like a great place to sort of create an app that puts all these calculations in the background. So you get a bump, you put the values of the bump in the app, and you put the problem that you're trying to address, and it'll do all these interpretations and calculations for you. Is there such an app?
I'm not aware of such an app. We could make one. It's not that hard to do.
Yeah, I mean, it seems like a pretty simple thing. And I know you know these calculations in and out, but most people out there would have to go look it up. And if you had it on your phone, then you would use it more.
I think so. We do have. I will acknowledge that the calculated urine osmolality it needs a little bit of fine tuning. The lab will give you that. Right now, it's not doing that right, because if the urine value is less than something, and it's the glucose is less than something in almost everybody, because non-diabetics are not going to have glucose in the urine. So then it says it can't calculate it. So they're working on it to convert that to a numerical value that can be translated into a calculated urine osmolality. I think we may be one of the first places to do that, and we can actually see how well it guides therapy, which is my hope.
So there's a question about urine anion gap and whether it differentiates proximal from distal RTA. I thought you said forget about it.
Forget about it. It doesn't work. All the urine anion gap is, so the urine anion gap was introduced, and in a small number of patients, it was shown to distinguish between metabolic acidosis from diarrhea and metabolic acidosis from renal tubular acidosis. The problem is that all the urine anion gap, the urine anion gap is determined by your diet. What your dietary intake is, and like I said, if you've got a glue sniffing as a cause of renal tubular acidosis, the urine anion gap will tell you that the patient has renal tubular acidosis. It'll fail. It's wrong. You need the osmolar gap. There's no added value of the urine anion gap, and it cannot distinguish between proximal and distal RTA in any case. Even when we thought that it was helpful, it wasn't helpful for that.
Okay, so there's a question from an anonymous attendee. How to evaluate kidney status in oliguric postpartum patient with hemolytic uremic syndrome delivered by C-section due to pregnancy-induced hypertension and cholestasis. I'm not following the entire question. How to evaluate kidney status is the fundamental question.
Yeah, well, I think it's a whole, the urine chemistries are not going to help you there.
No, right.
Unfortunately, there you need to be not just a piss prophet, but a real doctor.
Yeah.
Yeah. I mean, you might actually have to look at you may have to look at the blood smear, right?
Yeah, in that case, yes. So then as we diurese, sometimes the creatinine goes up. Will the bump keep on predicting the effectiveness of the diuresis in that setting?
Yeah, all you're looking at in the diuresis is whether here what you're just asking is the diuretic doing what I want the diuretic to do? Whether it is causing more sodium to come out in the urine than I started with. And that's important because the usual drill is we put people on diuretics and then we wait until the next day to see if their weight went down, and then they weren't weighed. Or if their urine output has been measured, and it seldom measured accurately. And so you can go for days ineffectively diuresing a patient. So that's the purpose of this, to give a diuretic, and a diuretic starts working right away. And so if you collect a urine shortly after you give the diuretic, that's at its peak effect. You get a pretty good estimate of how much urine is going to come out, and how much volume and how much sodium will come out as a consequence of that diuretic. And if it's inadequate, you just then, right then, 8 hours later, up the dose. What it won't tell you is how the patient's going to respond. I mean, it can't predict whether the patient's going to get hypotensive from being diuresed, or whether their creatinine will go up from being diuresed, but it'll tell you whether the diuretic is working or not. And that's why the cardiologists were interested in this. This had a prominent place in JACC, one of the top cardiology journals, and it was an accompanying editorial. So this is an important issue in cardiology, and we can use urine chemistries to help diurese patients effectively.
So Dr. Beaverbrands asks, will energy drinks or large creatine intake affect the bump?
Yeah, well, energy, I don't know what's in energy drinks, unfortunately. I don't know if there's certainly creatine supplements will increase creatinine excretion. So just like you will underestimate urine volume from the urine creatinine in a tall, young, muscular male, and those are usually the people taking creatine supplements, you'll underestimate that subject's urine volume a little bit. So the answer is yes. Creatine supplements, just like muscles, will make you underestimate urine volume. But again, these are rough estimates, and they're better than nothing.
I think that's great. That was a very useful talk. I have a name for your app already. It's Pisse Prophet.
So, there you go. Okay. Well, I'll tell you what. Our son is a math computer guy, and I'll set him to work on this for my birthday present. And and then we can market the Pisse Prophet.
That's right. All right. Thank
Okay.
you very much. And thank you all. See you next week.
All right.